by Dr. David Feldman of the Paley Institute. David, thank you so much for taking the time to talk to our viewers. Some of them will see you live and maybe have questions. Others will see this on what we call a rebroadcast. Dr. Feldman is a spine surgeon, correct?
Correct.
And you specialize in scoliosis, or that's one of the things that you treat is scoliosis. And we spoke briefly on the phone a week ago, and we agreed to talk about what you called modern scoliosis treatment. And I love that sort of title because the word modern is very interesting to me. I finished medical school in 1990, residency in 94. And so my sort of understanding of scoliosis is more primitive when it comes to surgery. And I would sort of say it's less than modern, meaning when I think of scoliosis surgery, David, I think it's something that really needs to be avoided because it's so brutal. And I have a feeling that there have been modern advances in what you do that make it a lot less brutal than it was back in the early 90s. Is that fair to say?
Yeah, I mean, thanks for having me. I'm happy to talk about this. And we both I graduated medical school in '88, so we both grew up in that same era of spine and of scoliosis and the treatments. And back then, even over the last, maybe a decade ago, basically, there was no treatment. Someone came in with scoliosis, you say either give them a brace,
right,
or we tell them that they need surgery, and then the surgery was really quite brutal, as you called it, or drastic, and fusions and everything else. And I think that there are so many options now from the beginning, with mild scoliosis to very much more severe scoliosis. So I think this has gone from a time when we talked about Harrington rods, that was always the line that we used when we were in medical school, to now minimally invasive and non-fusion surgery and different types of surgery. So one block of advancement has been in surgery, and there's also a block of advancement in non-surgical techniques. So I think that that's really what we want to talk about, is that it's not just, okay, we're a brace. If the brace doesn't work, then you need surgery. There are other options out there, which multidisciplinary options that may be very helpful for scoliosis or idiopathic scoliosis, meaning scoliosis that came about for no specific reason, that we don't know why it occurs. We know that it runs in families, but it has but if you would have said to me, can we do physical therapy for scoliosis? I would have said, no, that's not an option. And today it is an option. Today with Schwa therapy, that would be the initial treatment of scoliosis, of treating this condition with a specific type of physical therapy.
Tell us more about that. Let's start with the conservative advancements and work our way to the surgical advancements. So you mentioned a type of physical therapy. Say a little bit more about that to start with.
Right. So the physical therapy has been termed Schwa therapy. It was coined in both Barcelona and in Berlin by two brothers who designed this methodology for scoliosis. And I've been using it now for about 8 years, or having my patients go through it. And it's not a panacea, but it is a specific form of exercise and a specific training, and the therapist has to be trained in it, that align the body, that allow the patients to possibly correct their scoliosis. Mild to moderate scoliosis. And I put all my patients who are non-surgical within Schwa therapy. The worst it can do is strengthen your core. It's like an Uber Pilates. It's not easy to learn, but it is a very specific formula that the therapists teach the patient.
How do you spell that?
Schroth. Schroth or Schroth.
Okay. Schroth.
Right.
Okay. And so physical therapy. Now go on to some other, is there other, let's say, non-invasive treatments that you recommend?
So I think you begin with that physical therapy, a very specific one. It can't just be, I'm going to do swimming. That's not going to help your spine and not going to help your scoliosis. And then you move on to things like bracing. So bracing when we were early on in our medical school careers, was a Milwaukee brace, this big brace that those of us who are older remember. It was under your chin, and basically it was incredibly disruptive to someone's life. And if it cured your scoliosis, it certainly didn't cure your body image, because it was such a horrible thing to put on young women. So there are braces now that are, whether it's the Boston brace, or we use a Rigo Chenot brace, which is the same, or a Wood Chenot brace, which is the same sort of philosophy as the Schwa therapy. And we utilize that because we sort of we utilize this as a completely non-surgical approach to treating scoliosis. So we treat scoliosis with the Schwa therapy, and the correlate brace for that is a Rigo Chenot brace. And it has, or Wood Chenot brace, and it has specific formula to it where it's utilized to reorient the body in the same way the Schwa therapy does. Does it work better than the Boston brace? There's probably not any proof. The Boston brace is the other brace that we utilize.
You mentioned a genetic predisposition to scoliosis, and you also mentioned that the type of scoliosis that right now that you and I are talking about is idiopathic scoliosis.
Correct.
Which means idiot doctor, frustrating patient. That's
Right.
what idiopathic means.
Correct.
And I'm just curious, have we, since with our training, have we gotten any better understanding of what's underneath scoliosis? Is it, for instance, a dystonia? Could Botox be effective to treat a muscle imbalance that's pulling the spine in a crooked fashion?
So the answer is we're not much more. We know what it's not, right? We know it's not a muscle problem. I mean, now we're talking about what idiopathic means. We're talking about the type of scoliosis that adolescents or young adolescents get between the ages of 10 and about 15, 16, if that's when it develops. Bracing is only good if they're growing. But in terms of the condition itself, we don't know what causes it. So we're not talking about someone who has an underlying condition. They have cerebral palsy. They have some other underlying condition that makes them predisposed to scoliosis. Forget those. Or that their architecture of their spine is not correct. The building blocks are made incorrectly. That would be called a congenital scoliosis. Also not in this purview of this conversation, because it's completely different, treated differently, and absolutely can be discussed, but that's not the most common form. The most common form is just a healthy young person who maybe aunt had it, or mother had it, or father had it. More common in girls than in boys. Usually starts off about 2 years before a girl gets her period, when it becomes noticeable, or sometime in that range, in that time period. And we don't know. We don't know if it's caused by an imbalance in proprioception, meaning balance is a problem. We know it's not the muscle. We know it's not the bone. That's been studied, actually. Dr. Ponsetti, who cured club feet, studied all the muscles and the bones of when we had monoclonal antibodies come out, and he did research and found out that really the muscles and bones seem to be normal. Is it the brain that is somehow causing this? Most likely, but we don't know. And people have talked about hormones doing it, like something called calmodulin, but really, or melatonin, but we really don't have an answer for what causes it. We do know there are genes associated with it, that it runs in families, definitely runs in families, but we don't know the cause at all. So we have to treat it after that without being able to understand the cause.
So if we back up just a little bit, the reason we treat scoliosis is that if the curve progresses to 40 degrees or more, those patients, those individuals tend to have more problems in adulthood. And is 40 degrees still the magic number?
So I don't think there is a magic number. I think it depends on the age of the person. How much more growth do they have? Growth is a problem for scoliosis. So if you have a lot of growth left and you have a 40-degree curve, then that may be a bigger deal. But why do we use that number? Because there were studies done years ago on the natural history of scoliosis. And if you reach skeletal maturity and your curve is 40 degrees, so let's say you're a 16-year-old girl and you're 2 years post-menarchal, 2 years post the onset of your period, and you develop a and you have a 40-degree scoliosis. Well, chances are it will get 1 degree or 1.5 or 2 degrees worse per year of your life. So by the time you're 50 years old, you're gonna have an 80-degree curve. That's a big deal. It's a big deal from a functional standpoint, from a cosmetic standpoint. I don't think you have to worry about it causing, in this form, a heart and lung failure. There are some specific types that can do that. When you have no kyphosis, when you're completely like, your back goes inward. But in general, that's not the reason we're doing it. We're doing it because both it causes a functional problem to have such a huge curve, and also because cosmetically it becomes to look really pretty bad at a certain number of degrees. What degrees that is depends. So there is no, I don't necessarily operate on people who have a 40, if a skeleton mature person and a 16-year-old girl comes into my office and she had her period began 3 years ago with a 40-degree curve and she just noticed it, unless she was really debilitated by it psychologically, I would not think that she needs to have an operation. If it was 60 degrees, I would like to prove that it progresses in her adulthood, a couple of years. If it's 60 degrees, I think she should be operated on, because it's just going to get worse and worse and get harder to treat. And because there's ways now, and we'll talk about them, surgically not to fuse the spine, the sooner we can get in there and do that, probably the more levels we'll save and the more function we'll save.
I want to get to that. There is a question out there, so I just want to make sure I tackle that. Jerome writes, how early do you think mechanical factors play a role in the etiology?
Yeah, I don't think they do. I think that in terms of scoliosis that we're talking about, which is adolescence getting difference or something like that. Now, if you live your life with a limb length difference, meaning that one leg is longer than the other by an inch, then yes, you will develop what's called degenerative scoliosis. Eventually, because you've been walking on your back so asymmetrically, you'll get arthritis in your back, and basically that will cause back pain and a form of scoliosis. But that's not the form of scoliosis that occurs when you're an adolescent. So I don't think mechanical factors in childhood play a role in adolescent scoliosis. Do I think that if you live your whole life doing jackhammering on the street, yes, you're going to develop arthritis of your spine, which can then give you a secondary scoliosis in adulthood, which needs to be differentiated because it needs to be treated many times because it causes nerve impingement and things like that. But it's not the same as the one when what we're talking about in adolescence.
So let's go back to that 16-year-old girl who is skeletally mature with the 60-degree curve. Mm-hmm. That you felt like, hey, we really need to intervene here. And then let's also take that same sort of situation and say, you know what, I don't want surgery. Let's take that person. Now she's 30 years old, and how would treatment be different for the 16-year-old versus the 30-year-old?
Those are great questions. Those are terrific questions. I think that there are many options. We have to look at surgery now in a spectrum of treatment. The most tried and true treatment of a 60-degree curve in anybody would be a spinal fusion, which is when you weld together the area of the spine that is crooked from end to end, not from end to end to the spine, but end to end of the curve. So if the curve goes from your thoracic level 2 to your thoracic level 11, then you fuse. You weld that together, you put rods and you put screws at every level so there's no brace afterwards. They can play sports afterwards. I mean, it's really not like it was when we were in medical school. Having said that, we would still, let's say that's in the lumbar spine where it moves. You'd love not to weld together a part of the spine that moves, which is your lower back. So we're coming up with ways of not fusing the spine. So the 16-year-old, she has options. From the options we could talk about, well, could she have a tethering? Well, as a skeleton mature patient, it's certainly pushing a tethering. That's when you go to the front of the spine and we use like a rubber band to bring it together to push the spine. But we don't weld it together. We still allow it to move. And that's called a tether. And then we have something called apifix, which we just do the apical portion of the curve with a single rod in the back that allows for movement. And we think that can curve it. So that can cure it. But that's usually, we'll call that same 14-year-old with a 48-degree curve. Once we get to the 60-degree curve in a 16-year-old, most often we're talking about some kind of fusion. Why do it when you're 16 and not when you're 35 or 30? And the reason for that is because what's going to happen is maybe I can get away in a 16-year-old only fusing to T11 or some level where she doesn't lose much motion. As the patient gets older, the other parts of the spine begin to compensate for the curve that they have. That can give them arthritis, right? That arthritis can impinge on nerves, and that's when doctors like you get involved with them and try to relieve them of their symptoms of their nerve pain from impingement and from spinal stenosis and from things like that. And it causes all that. So if we can get in there and stop the bad mechanics earlier on when they're 16, they may not have a problem when they're 48 or 38 or even 30. If we wait till they're older, it may be a different story. It may be the same surgery, not as well tolerated, maybe more levels, and more difficult to really make it normal in quotation marks.
I'm not sure I completely understood the tether that you were explaining. Can you talk a little bit? You don't have any models there, do you?
I don't have them with me.
Okay.
But there are three non-fusion methods that people talk about. So how can we treat a scoliosis, treat a spinal deformity, but not weld the spine together, not fuse it? Because people worry about, well, if I fuse the spine, it's going to get stiff. I'm less worried about that in the chest. If it's in the thoracic spine where the ribs are and I make it stiff, we're all stiff there. The ribs make you stiff in your thoracic spine. But we all know the lower back is where we all get our problems, where all the motion comes from. And that's really where we need to work with. So there are three methodologies. If you're very young, under the age of, let's say, 10, then we can do something called growing rods. We put these rods in these days that grow like we do the legs when we grow them, and we can use a magnet and it actually expands the rod gradually and allows us to correct the scoliosis without fusing it, to allow the child to grow. So that's
it sounds like braces for your mouth.
It is, but these days we used to do it just like braces, it is. But these days we can do it with electronically, so you have to keep on opening up and keep on lengthening it. So we can actually do it with a magnet and the rod lengthens. In the same way we can lengthen a limb. So, but that's really, really good for very young patients, for patients who really have a great deal of growth left and we don't want to do something else. The other extreme is to say, okay, let's take someone who's older, but we don't want to fuse them in. We want to keep their motion. They want to play, competitive sports, and they're really worried about that fusion. And it's in their lumbar spine, let's say the scoliosis. Well, then we could do something called a tether. And what the tether is you go to the front of the spine or the side, either through this flank or through one of the ribs, the chest, and you put in screws and you connect the screws via like a rubber band, which I call a tether, which everybody calls a tether. And basically it allows for motion, but it actually corrects the scoliosis. And even if the rubber band breaks, which can happen, the scoliosis will accommodate to it and actually not get worse. There's other problems with that, like overcorrection and things like that, and you have to go to the side.
Do you put the rubber band or the tether on the concave side of the curve or the convex side of the curve?
So if it's in the lumbar spine, on the convex side of the curve, because you want to create lordosis. And if it's in the thoracic spine, you want to treat the kyphosis, so you do it on the convex side. So it depends upon where it is that what you do. So you do.
Wherever the convexity is.
You always do wherever the convexity is, right or left, but it's always where the convexity is.
Okay.
Because you're pulling it, you're compressing it.
So it's kind of, again, like the braces. You're kind of trying to bring that curve out.
An internal brace. That's exactly what I call it. It's an internal brace. But it's real surgery, and some of the things I have problems with it is, number one, we don't have as long a history using it. And number two, a scar that people see on their back does not bother them. I treat most people who need scoliosis surgery in adolescence are young girls, young women. Certainly their body image is very important to them. And they do not get bothered by, and if you look in the mirror and don't see your scar, it doesn't bother you. So when you look in the mirror and you see these scars on your side, that they may actually bother you. So that's one. Two, you're going through the chest or the side. It's still a big operation. It's not a small, we do it thoracoscopically, which means we do it with a scope, but it's still an operation. I'm much more leaning towards the next level of this, which just got FDA approved, which we're going to be doing, which is called ApiFix. And I've been following ApiFix.
Hold on to that thought. Frank wants to know, what is the tether made of?
Like a cord. It's like a cord-like material.
Well, like, what is that? Is it collagen? Is it?
No, it's basically it's just a synthetic material that actually brings it together. So it's not made. It has no biologic properties.
So it's inert biologically.
Really inert. Right.
But it's a cord. And does this cord stretch?
It does. It stretches a little bit and it compresses a little bit. But if anything, the problem is overcorrection, not undercorrection.
How thick is it?
it looks like a big, like a cord that connects, screws. I mean, next time we're on, I'll bring some, pictures of showing exactly, yeah, like that, but obviously it doesn't have that stretch to it. But it's a lot more hardy than that. It's a synthetic material that's made to be very hardy. It's not Kevlar or plastic. It's just
good. You can see it. We don't know exactly what it's made out of. All right, we're going to talk about ApiFix now, number 3.
ApiFix. So the API-FIX, and that basically was designed in Israel and trialed in Poland. And basically, what it is just basically doing it's not a wire, Frank. It's braided. Anyway, so basically, it is a material. I'm sorry, the ApiFix is basically a screws and a rod connected that has a ratchet in it. And it allows you just to have sort of a lot of degrees of freedom as you're correcting the spine. So you put it on the concavity, you distract the spine, and basically either you let it distract in physical therapy afterwards where it's ratcheted, or you do it in the operating room, but the screws allow for movement. So the spine can accommodate actually and does not get worse. And the results have been fascinating. I mean, I've reviewed all these results. I work in Poland, so it's been easier for me to review. And an option for a 45-degree curve in a younger patient, 14, 15 years old, and I think we're even 12. And I really think that it is a minimal operation with no loss of motion or very little loss of motion that I think may play a really a good role in our treatment of scoliosis, more so than even tether.
That's fascinating. What's it say? Your med device rep will know.
I also know. For some reason, it's actually just escaping me for a second, the exact material. It's not for a second, it's not bioabsorbable either. It's not like a PLA or PLGA.
So one more time, ApiFix. Exactly how does that work again? I'm sorry, because
it's a single rod that we put in that has ratchets in it, and it has complete degrees of freedom, or a lot of degrees of freedom, where the screws hook up to the rods. So you're not welding things together. You're not putting things together. You're allowing motion with it, and it allows the spine to accommodate. It allows your joints to accommodate the new position of your spine. Because if you just went ahead and just did anything like we do now, it will get stiff. This just allows for it to move.
Do you put them in? Where do you put it? Do you put it in the vertebral body?
From the back.
So coming in from the back.
Exactly. You come in on one side of the back, and you put in a couple of screws at the end vertebrae, a couple of screws on the top, and a couple of screws on the bottom, and connect it with this device that's ratcheted, and the screws have degrees of freedom. They're not holding the spine.
Are they going through the pedicles? Are they going through the pedicles?
Yes, they're pedicle screws.
So you could do this all percutaneously.
You absolutely could, but it's such a small incision, and you have to lay it down there. People are doing it, but it's almost easier just to lay it in. But it's a very minimal, home the same day, home the next day, back to activities. It's an amazingly small operation. You're not burying the spine, you're not welding, you're just putting it in.
And I think that's an important point to make because, again, when we started this discussion, we were talking about modern versus Harrington rods. Harrington rods was my day, big operation, stem to stern, and now we're talking about really minimally invasive, home the same day in terms of scoliosis surgery,
right.
Maintaining motion, not fusing.
Well, if you have to, I mean, fusion is still the standard of care for most cases, and it's a really good operation. And these days, you're out of the hospital a couple of days, you can do all your activities. I'm just giving other type of options when you can do it.
So here's some questions. You can probably read them as well as I do. Does the rod need to be replaced at some point, or does it stay in forever?
In both cases, the fusion rod and the fusion rods never has to come out unless there's a problem. A rod put in for ApiFix also can really stay in, and it can come out electively if we wanted it to, but it can just stay in. So they know they don't need to be replaced. We talk about growing rods. Sometimes the person will grow so much that they have to be replaced to allow for a growing rod to be replaced.
And then for what degree curves would you use the ApiFix?
So I think, right now it's best for curves somewhere between 35 and 50 degrees. I think that would be the best curve to use it on. And it does not have to be a skeletally immature person, but it's best if they maybe had a year of growth left. But that's really the curve, that 35 to 50 degree curve. In anywhere in the spine, you can use it, in the thoracic, in the lumbar, in the thoracolumbar, and that's really an advantage to doing it. And I'm very excited to start using it a lot more. I just became FDA approved right before, the entire country went down, right? But it is a really interesting thing to use.
And what is the typical physical therapy after the procedure? And another way of putting it down is, what's the typical recovery? What's the, how long before they're back to normal?
I was just going to, so very quickly, I mean, the physical therapy used to be, when they first designed this ApiFix, that they would use that they would only do it when they just leave it in, and then with therapy, you'd crank it out and do that. But now they think it's just as good, because it has so many degrees of freedom, is that we can crank it out in the operating room. So really, you're back to doing everything within a couple of weeks. Let the wounds heal up for 2 weeks and let people go back to their activities.
So there really is not a PT protocol, like when you tear your ACL, there's 6 weeks.
We do a PT protocol for all our spine patients to get their movement, because we like movement. So we want patients to move. So we try to let them, we all know when we get sick and lie in bed, that basically it makes your back stiff. So we don't want the back to get stiff. But it's a pretty standard of care of physical therapy.
Super. Well, I think we've covered a lot of ground, David.
While we were talking, it's a polymer. It's a type of polymer. It's actually a polyethylene terephthalate. For those of you interested in the material of the tether, it is Sulene, which is the trade name, Sulene, and it's polyethylene terephthalate, which I don't think I've ever said that word, but basically that's what it's made of. Because I felt bad, Frank, what it was made of. But in terms of these different options, I do think it's an exciting time for scoliosis. It's an exciting time to be able to give people different options, from non-surgical to to minimally invasive, to pretty tried and true, more invasive, where put pedicle screws at every level, fuse, and they can go right back to playing ball as well. So yeah, I think it is a really good time for scoliosis.
So before we say goodbye, I know you're a spine surgeon, and I know you're an orthopedic surgeon, right? So when you get into sort of the scoliosis treatment, which I think is sort of taking a specialized approach to spine surgery, is it a pediatric fellowship you do, or what did your fellowship consist of?
So mine was divided by, I did 6 months of pediatric orthopedics, and then 6 months of scoliosis surgery alone. So I don't think it matters if you're trained in spine surgery or pediatric scoliosis surgery. I think it matters if you're trained in scoliosis surgery. So if someone did an adult fellowship in degenerative spinal problems, they're not going to be able to treat scoliosis. And if someone treats scoliosis, doesn't mean that I should be treating and I do some adult degenerative, but a 68-year-old who necessarily has a problem with their spine. So it is just specific for that. That was my fellowship was a long time ago. I don't think I do anything that I did in my fellowship that I do now. And then I do spine and limb deformity. That's my thing. So deformity is sort of where I've led my thing. So the pelvis is connected to the hip. So the hip for me became all part of it. But all these deformities are really where I have really excelled. I don't do neck degenerative. If you have a herniated disc in your neck, I won't do that for you.
How does your practice differ from your partner's, Dr. Paley? Is he more deformity and limb length, whereas your deformity and spine? How does that differ?
Right. So we all specialize. He specializes in congenitals. Congenitals like some weird genetic conditions like fibrohemilia and things like that, and congenital, really severe congenital anomalies, and then limb lengthening. And he doesn't do any spine surgery. I would be the only one there. We've now joined up with three other spine surgeons, myself, Dr. Ashgar, do a lot of the scoliosis, Dr. Cantor, and then we also have someone you trained working in physical medicine. So we try to give the complete treatment, because I may be a spine surgeon, but I'm not going to be injecting the L4-5 facet like you would, or doing rhizotomy. So I think each of us do that. So each of us have our specialties within it. I do a lot of, I try not let people get hip replacements and do, it could be a different conversation, and save their hips. So, then all the way up to age 48, 50. So each of us sort of have our own specialties within the Institute, but all of us are deformity surgeons in some way or another.
Frank has another great question, an interesting question, and he says, how common is kyphosis? And we should talk about scoliosis in terms of that type of curve. So,
right. So scoliosis is a curvature to the side. So it means your spine is curving. If you're looking in the mirror, it's to the right or to the left. A kyphosis would be a hunchback, basically, right? You have a round back. Normally, you have a round back. Up to 40 degrees of being round is normal. Having a totally straight back is really not the norm. So up to 40 degrees would be normal.
So can I tell my mom that slouching is normal?
Slouching is good for you. No, obviously, you don't want to slouch and you want to do Pilates. But kyphosis in a normal round, there's a normal round curvature to the back.
Oh, am I losing you?
So that is.
I lost you for a second. Just back up.
No.
You're talking about kyphosis being normal up to 40 degrees.
Right, and that's where I forgot who asked me the question about mechanical. That was Jerome asked me a question about mechanical problems initially, and that's where it plays a role. So mechanical problems as a child, sitting hunched over a game, whatever games they play today, whatever the game du jour is now, can give you kyphosis. I mean, that because you're growing and you're putting forces on the front of the spine, you can develop a hunchback and a round back, and early on can be treated only with exercises, sometimes bracing. But that's where exercises plays a really, really, really important role. So unlike scoliosis, kyphosis is a mechanical problem that occurs because we're not doing enough extension, or because you're genetically predisposed to it. And exercise is the key. Pull-ups, anti-kyphotic exercises, and then in the adult, it gets obviously more, significant. It can be braced as well, and it's very effective in people who are still growing. Bracing is ineffective and contraindicated, meaning it's very poor treatment for someone who is not growing, and that's because it makes you weak. So it just takes away your muscle strength, which you don't want to do.
It says, is kyphosis increasing because of handheld device use?
Yeah, it's a good question. That's a very good question. I mean, I think that we don't know if it's increasing or not, honestly, but there's certainly communities that I see it in, and certainly couch potatoes get kyphosis more often. So kids who play, varsity sports rarely will get kyphosis, although swimmers can get it because it's a very frontal sport, swimming. So they need to give exercises that give them extension exercises as well. I do think there is really treatment and management by coaches in young ages and in adults, giving you exercises that can really make the back strong, and surgery is the last resort by far for kyphosis.
And I've heard you mention Pilates a couple times. So you're very, it sounds like you're very pro Pilates. Will you talk about that for a second?
Yeah, I'm very pro Pilates. I mean, it's a minimal impact on your body, meaning in terms of on the joints, it has no real high impact effect. And I think taken with something else someone is doing for aerobic exercise, because Pilates may not be enough of aerobic exercise, like elliptical or a treadmill or something that you want to do, or a bicycle. Pilates is excellent for the core, excellent. And I think that's what we're talking about. So the cheapest body exercise for the core is get a pull-up bar, not chin-ups, but pull-ups. $10 at your favorite sporting goods store, hang it up at your door, and everybody does pull-ups, and everybody helps one another because you're all stuck at home anyway. And basically, you can all learn to do pull-ups, and that's really good for your upper back. I think people look in the mirror again, they see their pecs, especially young, boys and teenagers. They look at their pecs, look at their chest, they want to build it up, and they become round-shouldered because they're not doing anything to strengthen their back, like rowing machines and Pilates and pull-ups, and all those are really excellent for your back.
David, I want to thank you so much for taking the time. It was fun
Yeah,
to talk, wasn't it?
yeah, it's great.
I enjoyed it. I hope you did too, and I appreciate all those folks who wrote in with questions. Frank, great questions. Really, everybody. Hala Ermilla had a comment. I appreciate everybody for doing that. If you have more comments, please feel free. If you can maybe give Christy some pictures to post,
Sure.
that might be great. And I really much enjoyed it, David. Thank you so much.
It's great talking to you. It's really a pleasure. My pleasure.
I'm going to stop streaming.